Good afternoon, everyone. Uh, from Unit 2, we are going to present the CGR on gynecological laparoscopic surgery in COVID era, the first wave actually. Now, the idea of presenting this CGR was basically that the difficulties and dilemmas we faced during that period, and we learned the lesson. And this lesson may be useful if there is any third wave which may or may not come. The challenges we faced because of the evolving, changes based on facts and evidence in the literature. There are new SOPs, new guidelines, new administrative decisions, new policies, but we try to do whatever way possible to take care. And I must tell you, despite all the constraints, because of the cooperation from everybody and particularly the anesthetist, not only cooperations in the coordinations and the ground staff, the other staff, the heroes, I always call sweepers as the heroes, we could do whatever we could do. So I will request Dr. Rinchin to introduce the subject and take you to that journey which we had undergone. Thank you.
Thank you very much, sir. Good afternoon, everyone. So today, from the Department of Obstetrics and Gynecology, Unit 2, we will be presenting our CGR on gynecological laparoscopic surgeries in COVID era, from skepticism to pragmatism. So after the introduction, we will have Dr. Ashmita, MIGS fellow from our unit. She will share the data with us. And Professor Anjuli from the Department of Anesthesia will share the anesthesia perspective, and then we will have the discussion. The World Health Organization declared the COVID-19 as a pandemic on 11th of March 2020, and soon after the declaration of the pandemic, surgical disciplines were instructed to postpone all elective surgeries so that diverse resources and manpower could be diverted for the care of COVID-19 patients. So what were the changes in AIIMS at that time? So immediately after the pandemic was declared, all OPD services were closed. Emergency and essential services were continued. Minimally invasive surgeries were stopped. And there were certain major administrative changes like the trauma center of AIIMS and the NCI Jhajjar being converted into dedicated COVID hospitals. So what was the concerns among surgeons and societies at that time? So there was a fear of infection among all the healthcare workers at that time. Among the surgeons, the fear was because of the theoretical risk of surgical smoke containing COVID-19 virus particles, and also studies from the past which showed that viruses such as hepatitis B and HPV can aerosolize in the smoke evacuated during laparoscopic surgeries. And soon after the pandemic was declared, the Society of American Gastrointestinal and Endoscopic Surgeons was one of the first societies which came up with the alarm that risk of COVID-19 transmission is there with laparoscopic surgeries, and they advised that laparoscopic surgeries should not be done during the pandemic. After this guideline, after a month of this guideline, the major societies like British Society of Gynaecological Endoscopy, the RCOG, and the American Association of Gynaecological Laparoscopists came up with guidelines that laparoscopic surgeries can be performed during the pandemic, provided all precautions for proper smoke evacuation and for this care of aerosol generation is taken. So after these guidelines had come, slowly the laparoscopy was resumed in AIIMS as well, especially the emergency services. And now I would like to ask Dr. Asmita, our fellow, to present our data of 6 months during the first wave of COVID-19 pandemic.
Thank you, ma'am. I'm here to share our story of grit and perseverance during the first wave of our COVID-19 pandemic, when surgery, and more so minimally invasive surgery, was discouraged by various surgical societies throughout the world. Thank you. During the 6 months span of time from August 2020 to January 2021, During the 6 months duration of time from August 2020 to January 2021, total of 60 patients underwent laparoscopic surgery. 31.67% of the cases were emergency cases. 31.67% of the cases were emergency cases, which included ectopic pregnancy and torsion of the adnexal cyst. 68.33% of the cases were due to heavy menstrual bleeding, either due to fibroid or adenomasis, which could not be managed medically. And there were also malignant gynecological cases like endometrial CA. 85.7% of our patients were less than 50 years of age. 28.6% of our patients had hypertension as comorbidity, and 14.3% of the patients had diabetes as comorbidity. Heavy menstrual bleeding, either due to leiomyoma or adenomasis, formed the most common indication for us performing the surgeries. We tried to manage the patients medically, but they did not respond, so they had to be put up for surgery. 40% of the cases were heavy menstrual bleeding due to leiomyoma, and 11.7% of the cases were due to adenomasis. We got 6.7% cases of dermoid cyst with torsion, 11.7% of the cases with torsion of the ovarian cyst of non-dermoid origin, and 13.3% cases of ruptured ectopic pregnancy. The apparent increase in the number of emergencies could be explained by the fact that during the first wave of the pandemic, many hospitals in the private sector were not providing surgical care, and many government hospitals were converted to COVID designated hospitals, which were not providing surgical care for the COVID negative patients. This pie chart shows us the surgeries that we performed in the number. 21 total laparoscopic hysterectomies, 9 laparoscopic mammectomies, 8 laparoscopic salpingectomies, 5 hysteroscopic mammectomies, 8 laparoscopic cystectomies, and 3 laparoscopic unilateral salpingoophorectomies were performed. This table gives us an insight into the surgical time, the average surgical time taken for the surgeries, the number of personnel scrubbed, and the mean duration of post-operative hospital stay of the patients. In pre-COVID era, the average time taken for a total laparoscopic hysterectomy in a simple case was around 45 to 50 minutes. But here we see that the time is increased to 95 minutes. This is due to the fact that we had to follow COVID relevant behavior. We had to follow certain protocols to minimize and manage the smoke, the smoke evacuation protocols had to be followed, which led to increase in the surgical time. The number of personnel scrubbed, including the nursing officers and the surgeons, were decreased from 6 to 4, so that the exposure of the healthcare workers were minimized to COVID-19 virus. The major advantage of minimally invasive surgery is that the length of post-operative hospital stay of the patients were significantly reduced. We could discharge patients after total laparoscopic hysterectomy in 2 days, after hysteroscopic mammectomy in 1 day, and laparoscopic cystectomy in 1 day. This reduced hospital stay helped us to reduce the exposure of the patients to certain nosocomial infections and also possible COVID-19 virus. No major perioperative complications were noted in our patients. None of the patients required ICU stay. One of our patients was inadvertently exposed to a COVID positive patient in the ward, but she did not turn out to be positive after 2 weeks of the surgery. None of our patients acquired COVID infection within 2 weeks of the surgery, and none of the cases had to be converted to laparotomy. During the initial preoperative workup phase, 9 patients, all of whom were semi-emergencies, tested positive for COVID-19. The surgeries of these patients were deferred. The surgeries were rescheduled after a gap of 4 to 6 weeks after the patient had recovered clinically. During rescheduling of the surgery, COVID-19 RT-PCR test was sent again. But sometimes these tests came positive even long after the clinical recovery of the patient. This could be explained by the fact that RT-PCR being a very sensitive test, sometimes it detected dead virus particles. But this led to undue delay of the surgery and prolonging the agony of our patients. In the surgeries performed in these COVID recovered patients, no post-operative complications were noted and the surgeries went on smoothly. Among the hospital staff involved in handling of the patients in the operating room and the wards, 3 resident doctors, 1 nursing staff and 1 OT technician were infected with COVID-19 during our study period. The source of the infection could not be pinpointed. Probably they acquired the infection from the community. Another point is that our resident doctors were posted in various parts, in various wards, in the labor room, in the OT, in the casualty. They could have acquired the infection from any of these places or from the community. 1 attendant was allowed with each patient in the ward who were clinically screened for the risk of COVID infection. Attendants less than 50 years of age and without any comorbidities were only allowed. It was ensured that the same attendant accompanied the patient throughout their hospital stay. But no virological testing in the form of CBNAT or RT-PCR was done for the attendants. We had to follow certain precautionary measures during laparoscopic surgery, which were in line with the guidelines issued by the international bodies. Universal SARS-CoV-2 virology screening was done in all patients who had to undergo surgery. All surgeries were conducted by an experienced and senior most surgeon to ensure that all the precautions related to COVID precautions were taken, and minimum duration of the surgery and the surgery took minimum duration of time. Surgeons and personnel present in the operating theatre were in appropriate personal protective equipment, which included disposable gloves, disposable fluid-resistant gown, N95 mask, and disposable eye protection. The number of OT technicians were reduced to 1. Ground staff were minimized. The surgical team entered the operating room at least 15 minutes after the induction of anesthesia, because intubation is an aerosol generating process and which could lead to a high volume of viral load. The minimum distance between the members of the surgical team was maintained at 1 meter. Disposable trocars were used. Seals of the trocars were properly checked for leaks. Incisions were just adequate enough so that the trocar and cannula could be inserted. Surgery was conducted at a low intra-abdominal pressure, around 10 to 12 millimeter of pneumoperitoneum. Port taps were closed before the trocar was inserted. It was ensured that a minimum venting of the ports were done in the intraoperative period for smoke evacuation. Instrument exchange was also minimized. All these steps ensured that there was a minimum leakage of pneumoperitoneum into the open OR environment. Handling of surgical plume received much attention during the present pandemic, because it was thought that there was a theoretical risk of viable COVID virus particle being present in the smoke, which was created during electrosurgical or ultrasonic instrument usage. So, proper smoke evacuation systems had to be in place to remove the surgical plume. Laparoscopic suction was used to remove the surgical plume before specimen extraction through the port or extracting the uterus through the vault after total laparoscopic hysterectomy. This picture shows us the smoke evacuation system that we used. This double arrow points towards the gas cable, which is connected to one end to one port, which is designated only for smoke removal by a designated member of the surgical team. This is the HME filter, the heat and moisture exchange filter, through which the smoke is passed, and after that the smoke is passed to the central suction through this tube. Electrosurgical and ultrasonic devices were used at the low power setting. Prolonged activation of energy sources were avoided. Prolonged desiccation of the tissue was avoided. All this was done to minimize aerosol generation. At the end of the procedure, before the port removal, suctioning was done to desufflate the abdomen. Surgical drains were utilized only if absolutely necessary. Port closure was done after proper desufflation of the abdomen. At the end of the surgery, after the surgical team left the OT, extubation was done. Thank you. Now I would like to request Professor Anjoli Madam to shed light on the anesthesia perspective of the surgeries. Thank you.
Thank you very much. A very good evening to all of you. And I think the COVID-19 pandemic has been a challenge for all of us. I'd like to bring the anesthetic perspective to you. So, like we all know that the anesthetists, because of their job of managing the airway and examining the airway, are exposed to respiratory secretions. and respiratory secretions have the highest viral load, and they're the main method or main source of person to person transmission that can occur either through close contact and droplet generation or through aerosol generation. I'll be coming to that a little more in detail later. The other problem is, like we all know, that though the patients at the time of symptoms have the highest viral load, but pre-symptomatic patients have also known to have the virus in the respiratory tract 1 to 3 days prior to symptoms. The virus, like my colleague said, can persist for very long periods of time, sometimes for 8 to 21 days, depending upon the severity of illness. And about 23% of the infected patients may be persons may be asymptomatic. So all these patients are patients who, if we ask them to remove their mask and examine the airway, an anesthesiologist can get exposed to the virus when they encounter these patients. Now, there's always a lot of debate about how the virus is transmitted. So I thought I'll just talk a little bit in detail about that. So droplets are particles which are more than 20 microns in diameter, and they are generated when a patient coughs or sneezes. They have a ballistic trajectory and they fall on a person or a surface within a 1 to 3 meter distance. And if the surface is non-porous, these droplets can remain viable for 72 hours. So this is the main basis for enforcing social distancing and hand hygiene. So this is the main way that the virus is supposed to get transmitted. But with whatever limited knowledge of the coronavirus 2 infection that we also have not been able to rule out aerosolized particles as source of infection transmission. Aerosolized particles are smaller, 5 to 20 microns in diameter. They remain airborne for longer, they get evaporated, and they are carried by air currents for longer periods, longer distances. And they can transit the upper respiratory tract of a normal healthy person and go and deposit in the distal respiratory mucosa, causing infection. Now, an aerosol generating procedure is a procedure that has the potential to cause greater likelihood of aerosol generation than that produced by volitional coughing. So, more aerosol than that produced by normal coughing by a patient. And in the anesthesia setup, it's the bag mask ventilation, it is intubation, extubation, and respiratory tract suctioning, which are thought to be procedures that can result in aerosol generation. Various studies have tried to simulate and find out what procedures result in more aerosol generation. One study carried out in an ultra clean laminar flow OT found that volitional cough and extubation caused more aerosol generation than endotracheal intubation. Whereas another study carried out in a standard positive pressure OT found that bag mask ventilation can lead to aerosol generation to the tune of 30 to 300 times more than that is normally there in a theater. And this is more than that produced during endotracheal intubation, and extubation and cuffing have the similar amount of aerosols generated. So, keeping this in mind, during airway examination as well as during management of the airway, personal protective equipment has to be worn, which for anesthetists includes very tight fitting N95 masks. Face shields are preferred over goggles for eye and face protection. Caps are essential. Gloves, disposable, have to be worn. And if one is planning to intubate, then water resistant gowns are also recommended. And one should take care not to touch the front of the face shield after intubation or extubation, or the front of the mask also, in fact, because these are the contaminated areas, and after they're removed, proper hand hygiene has to be practiced. What is important is that we should limit the number of personnel in the OT during intubation and extubation, because that limits the number of persons who are exposed to the aerosols. Now, the intubation is to be performed by the most experienced anesthesiologist with a single assistant. And after instituting standard monitoring, it is recommended to go ahead for a rapid sequence intubation. This involves intubating the patient and not doing bag mask ventilation before the endotracheal tube is inserted and the cuff is inflated. So we pre-oxygenate the patient for 5 minutes, slightly longer than we normally do. We do not do any bag mask ventilation after we've administered propofol. We use drugs like succinyl, choline, and rocuronium, which can induce paralysis enough for endotracheal intubation in a short period of 60 seconds. And we can use video laryngoscopes if we want, or we can also use standard laryngoscopes since these patients were not COVID positive. And after the endotracheal tube is inserted and cuff is inflated, only then we start mechanical ventilation. In addition, like my gynecological colleagues have said, good analgesia is very important. And we can provide this by supplementing GA with neuroaxial or regional anesthesia techniques. That way, we avoid giving too much opioids to the patients and causing post-op nausea, vomiting. Maintaining adequate muscle relaxation and a deep plane of anesthesia are imperative intraoperatively, because every time a trocar is removed or the specimen is removed, the patient will not buck or will not jump, and the surgical plume will also not be released into the OT. So these are essentials for this COVID era. To protect our anesthesia workstations, we usually insert a heat moisture exchanger and a good quality viral filter. They have both the properties just after the endotracheal tube and just proximal to the Y connector of the circuit. And this viral filter is changed after every patient. In addition, to provide extra protection, another filter is kept just between the anesthesia workstation and the expiratory limb, and this is kept there for the whole day and changed after the end of the day. The viral filter also has to be proximal to the port where the anesthetic gases sampling tube and the end-tidal carbon dioxide gas sampling comes out. So we have to insert the HME and the viral filter just proximal to that. Again, during extubation, minimal number of personnel should be there in the OT. Good prophylaxis for post-op nausea, vomiting is essential, because again, a vomiting, retching patient will tend to generate aerosols, and this is standard practice to give dexamethasone and ondansetron for laparoscopic surgery. And if we feel that the patient has high incidence, gives history of high incidence of PONV, we can add perinorm as well. Excessive cuffing during extubation can be avoided by injecting lignocaine IV, and we avoid out of OT extubations again to limit the exposure of other personnel to the aerosols. And usually a patient has a face mask on for providing oxygen, so that even if they cough, they don't generate aerosol into the atmosphere. And after each case, there is a thorough cleaning of the surfaces of the anesthesia workstation, change of filters, and of course, hand hygiene has to be taken care of. And only then do we take in the next patient. So thank you.
Thank you, Anjali ma'am, for a wonderful insight. Coming to the discussion. So what are the concerns during laparoscopy surgery in the COVID era? Any surgery involves close contact between the surgeon and the patients, and the duration of exposure can sometimes be prolonged depending on the nature of the surgery. Almost all surgeries involve aerosol generating procedures. Asymptomatic or pre-symptomatic COVID-19 patients have full potential for transmission of infection. What are the routes of spread of SARS-CoV-2 in laparoscopic surgeries? So the most important route is obviously respiratory droplets, and the highest risk of transmission is with intubation and extubation, as ma'am just stated. In laparoscopy, large amount of surgical plume are produced in higher concentration as compared to laparotomy, so that can be a potential source of COVID virus particles. The smoke generated by ultrasound scalpel has lower temperature, so therefore they might contain more infectious particles than smoke of higher temperature. The risk of leakage of aerosol generated during laparoscopic procedures is highest during insertion of trocars, removal of trocars, and during specimen retrieval. So what are the challenges that we faced during the preoperative phase in the first wave of COVID-19 pandemic? First was regarding testing for COVID. So initially when COVID-19 pandemic came, we had RT-PCR, which was the test available for getting patients admitted and for posting the patients inside the OT. And gradually we had CBNAT also available. And when initially CBNAT was available, despite of its availability, for the patient to be taken in the major OT, we had to have a negative RT-PCR report. Even patients with negative CBNAT report had to undergo an RT-PCR test for OT. The advantage of CBNAT was earlier reporting, so it was a boon for us for managing emergencies. Second was the duration of validity of RT-PCR and CBNAT. For each and every admission, we had to get the patient's COVID testing done, and patients with negative report could get admitted to the ward. It is still followed. This protocol is still followed, and by the time the patient could get posted inside the OT, it would be already 72 hours since the last report, and therefore most of the patients who were semi-emergencies had to undergo COVID testing twice before they could be taken into the OT. The window period of 72 hours is still followed in our department. Next was limited number of staff available. To follow all COVID precautions, the number of staff inside the OT was minimized. So we had only one OT technician and one ground staff to manage all the cases in the operation theatre. And then the next issue was bed constraints. As the trauma center of AIIMS was converted into a dedicated COVID hospital, trauma care was shifted to main AIIMS, and because of this, there was reshuffling of beds among the other departments of the AIIMS, and also among each within each ward in each cubicle, we had to remove certain number of beds to increase the spacing between the beds, so that risk of infection was minimized. So this led to an overall decrease in the number of beds that we had. Next was admission issues. So there were multiple checks at various levels with rigorous admission protocol. This was something which was obviously required at that time, because we had very limited number of beds available, and we really had to screen which are the patients who are really needing admission. So this made the admission process somewhat cumbersome, but it was something which was required at that time. Inside the operation theatre, steps to prevent viral transmission during intubation and extubation led to a prolonged anesthesia timing. Surgical time was also prolonged with respect to non-COVID times due to minimum number of surgeons scrubbed and diligent follow-up of protocol for smoke evacuation. So laparoscopy versus laparotomy. Laparoscopy has all the advantages of early recovery and shorter hospital stay. And this short hospital stay is pertinent in view of COVID pandemic, because with shorter stay, there is less risk of transmission of infection from one patient to another, or from the healthcare worker to the patient. Apart from these advantages of laparoscopy, there is less risk of spillage of blood or body fluids, and also limited exposure to surgical smoke due to the closed space, provided all precautions for smoke evacuation are diligently followed. Also in laparoscopy, there is greater distance between the surgeons and the patients as compared to laparotomy, thus again minimizing the risk of infection. So the RCOG and the British Society of Gynaecological Endoscopy came up with a statement that blanket approach for laparotomy for all cases during COVID-19 is not appropriate, and whenever feasible and whenever appropriate, laparoscopy should be preferred over laparotomy. Coming to the review of literature. So this first study, it was a retrospective study conducted over a period of 8 weeks. This was published in the British Journal of Surgery. In this, they had taken emergency and cancer patients across the specialties of upper GI, colorectal cancer, and gynecology. And out of 128 patients, 86 were operated by minimally invasive surgery. And PCR for COVID-19 was done whenever feasible. And in this study, in the post-operative period, they did not report any COVID positive case among the patients or in the theatre staff in the minimally invasive surgery group. The next study was published in the Journal of Surgical Oncology in August 2021. It was a prospective study conducted over a period of 14 months. There were 129 patients in total, of which 32 were operated by minimally invasive surgery. Pre-operative COVID RT-PCR was done in all these patients. Of these, 8 tested positive for COVID, and one of these had to undergo emergency laparotomy. In the post-operative period, none of the patients had COVID-19 infection. There was no readmission due to COVID-19 symptoms. And in this study, infection in healthcare workers was not assessed. The next was a narrative review published in the Journal of Surgical Endoscopy in May 2020 by Menz et al. In this, the authors stated that surgical smoke has same composition, either it is laparoscopy or laparotomy. So with proper evacuation techniques, laparoscopy is a safe surgical modality. But they also stated that evidence-based research is needed for definitive determination of safety of laparoscopy in the pandemic. The next study was a systemic review of literature published in the Journal of Surgeons in March 2021. It was a review of 34 articles. And in this study, the authors stated that there is no evidence directly linking surgical smoke with viral transmission, apart from active HPV infection. They stated that inhalation of surgical smoke is generally hazardous, whether it is COVID or not. So use of PPE and smoke evacuation technique is recommended in any case for the safety of the healthcare workers. Another study published in the same journal in April 2021, it was a systemic review of recommendations. In this, they included 22 articles, and the author stated that no case of virus transmission through surgical plume is confirmed as of now, but no research is conducted till now that refutes such a possibility. And we cannot say that any space in the abdominopelvic cavity is virus-free. They concluded by saying that laparoscopic surgeries can be performed during the pandemic with all precautions because it has its own benefits compared to laparotomy. So all these above studies and the reviews suggested that there is no scientific data till date to support transmission of SARS-CoV-2 with surgical smoke, but still all due precautions have to be followed in view of the theoretical risk. This was a landmark study which was published last month in the Journal of Minimally Invasive Gynecology. This was a prospective pilot study conducted in a COVID-free cancer hospital in northern Italy. In this, they included 17 patients who underwent minimally invasive surgery for gynecological cancers. All the patients were screened by a questionnaire, clinical examination, and by CT thorax for COVID-19. Those patients who had CT findings who had positive findings on CT, they underwent RT-PCR. So out of here, what they did, they took swab from the endotracheal tube and from the trocar valve filter for COVID-19 RT-PCR. So out of these 17 patients, one patient had SARS-CoV positive report on the swab taken from endotracheal tube and also from the trocar valve filter. And another patient had positive report from the swab taken from the trocar valve filter. So this was one study which showed that the laparoscopic fume or the aerosolized peritoneal fluid can contain COVID-19 virus particle, but they also concluded by saying that despite of this, laparoscopy can still be performed provided due precautions are taken. This was the study that we just presented. We got it published recently in the Journal of Obstetrics and Gynecology Science. Now, certain recommendations based on national and international guidance and from data extrapolated from other viral infections. These were recommendations, these were joint recommendations by British Society of Gynaecological Endoscopy, European Society of Gynaecological Endoscopy, and American Association of Gynaecological Laparoscopists. So the first recommendation was that, which still should be followed, is non-surgical treatment should be utilized whenever possible in the peak of pandemic. Universal SARS-CoV virology screening should be done in all patients undergoing surgery. A negative pressure environment is important to reduce the risk of transmission of virus beyond the OT. And laparoscopic procedures should be undertaken by the most experienced surgeon available to ensure full knowledge of safe procedure and also to ensure that the procedure is performed in the shortest possible time. Enhanced PPE is mandatory for all theatre personnels. Active smoke evacuators should be used. Some practical measures during laparoscopy to be followed. Most of these have already been discussed by Dr. Ashmita. Just to recap, during port insertion, the port tabs have to be closed, and once placed, the port should not be vented if possible. The incision size should be as small as possible to minimize leakage of gas. And specimen should be removed only after carbon dioxide gas and smoke is evacuated completely. Surgical drains should be used only if absolutely necessary. Endoclosure device for closure of port should not be used because they increase the risk of pneumoperitoneum leakage, and operation theatre should be disinfected after each case according to infection control guidelines. So should smoke evacuation techniques still be followed if the patient is COVID negative? Yes. Because the patient can be in the window phase, and secondly, the COVID-19 report can be false negative. Apart from the risk of COVID-19, the average daily exposure to surgical smoke in an operating room is equivalent to around 2 dozens of cigarettes smoked in a day. So for the safety of healthcare worker, it is advisable to use N95 mask and smoke evacuation techniques if available. To conclude, with the appropriate screening measures in place and adequate precaution, gynecological laparoscopic emergencies and semi-emergencies can be performed despite the constraints caused by the pandemic. Although surgical time can be slightly prolonged, but surgeries can be performed with equal efficacy. And given the advantages, laparoscopy should be the preferred mode of surgery during the COVID-19 era. Thank you.
So at the end, I must say that despite difficulties, despite all challenges, that we could do whatever we could do. And I must thank everybody, including the ground staff there, anesthetist once again, that we could do something even everything was closed. It is open for discussions. Before that, Professor Nirja Madam, Professor Devi Sharma sir, like to give some.
So I think that was a very nice
Thank you.
overview of the entire MIS. I think during the start of the pandemic, there were a lot of reservations on the outcomes with MIS. And I think this is a good overview of what is our own personal experience, which ties in very well with what is now reported. And it does appear that we can do things safely. In fact, many people were already doing some of these things before, including the suction from the ports, not letting the air escape into the OT environment and all. And some people have practiced this even in our hospital, the surgeons, especially for cases with septicemia and those type of cases where there is fear that the aerosolization into the environment. And of course, our masks are better than they used to be before because we are now wearing the N95 and probably even double masks sometimes. But it's a very good compliments to the entire team.
Thank you. That's all.
I think Madam has said it all. So I also congratulate Dr. Professor Roy and the team for the wonderful work. Yeah, it's really great. My only worry that did any patient turn out to be COVID positive, whom like you operated and thinking to be COVID negative? Like, remember initially in antenatal patients in New York, some patients even COVID test was done, it was negative, but later on they became positive. So our main worry is because all your patients were COVID negative actually. So, yeah, because then there is main risk of transmission. No, I mean any patient like that.
Yeah, actually, it is said that universal precautions you take in HIV, you should take the same universal precautions because many of them may be false negative. In fact, we had 9 patients COVID positive after they were admitted. I think before admissions, but they were exposed because our residents took the sample and all. But somehow then after 4 to 6 weeks, they became negative. And then though till they become negative, we did not touch her. It caused some delay, but ultimately, the outcome was all right. You are very right that you have to take universal precautions. Even today, even they are COVID negative. Yeah.
And in the study in the world literature, any patient like exposed ruptured ectopic or think they did laparoscopic surgery, it was COVID positive. Any such study?
I did not come across.
So normally in COVID positive, we avoid laparoscopic surgery. Yes. That is for absolute contraindication virtually.
Unless like we do over here that the COVID positive and emergency ruptured ectopic, they are done in the suspected area if the infrastructure allows you, because sometimes in the suspected you may not get the infrastructure. But in fact, in emergency also taking all the precautions, it can be done.
So in
but
general,
we have not come across COVID positive and laparoscopic surgery.
So in general, COVID positivity is a relative contraindication for laparoscopic surgery at that time.
No, but can because the last one, the landmark that study, it was 17 patients, and this in 17 patients, the CT findings were suspicious, but 2 of them, they were actually COVID positive. That is why it was in the endotracheal tube and it is from the trocar also, the swab became positive. So in fact, they were positive. But still they have recommended that if you follow the clear guidelines, of course the precaution has to be taken, every stringent measures have to be taken. You can still go ahead because you have the advantages of laparoscopic surgery. The main advantages which we felt, I think everybody knows there were only 7 beds And then the turnover time, on the second day, maximum by third day, all patients were discharged, so that we could, recruit more patients and then put this. So that
Congratulate.
advantages can be really exploited.
We congratulate you and Dr. Anjali also.
Thank you.
Thank you for your help. You are the first case also.
Yeah. And Professor Rajeshwari has sent a message with her good wishes. She could not come because she was busy in some operations. Thank you very much. Any questions? Anything? Any comments? Questions? Garima wants to say something. Garima. I'll be very happy if she says something, because she is indirectly or directly in my team.
Part Sir, it is very encouraging data, and very encouraging for us that these many cases were you were able to do when the whole hospital was down. So definitely you have showed that you have taken all the precautions, and it's very nice that no patient turned out to be positive, and even the healthcare were protected. Nice studies.
Thank you. Thank you. If there are no questions, then I think thank you everybody once again.